without further ado, the queen, the diva, the one and only, Chanel-wearing Dr. Afzali.
And this is what I have to put up with every single day. Thank you, Scott. Okay, so let's now talk about treat to target, and my hope is to be able to provide a practical guide in IBD care. Here are my disclosures. So what are our current goals when we are managing our patients with inflammatory bowel disease? So from here, you can see that we have plenty of goals and what we should incorporate on our day-to-day practice. Of course, we want to make the diagnosis accurately and quickly, right? We know that there is oftentimes a delay from the time that the patient even presents to us in clinic, but then also from the time that they present to the time we actually can accurately diagnose them. We need to be able to differentiate disease activity from disease severity, and I'll define those for us. And of course, patient-reported outcomes, improvement in their symptoms is very important. To date, I can't imagine any patient wanting to be on a therapy if it's not improving their symptoms. So keep that in mind. We also would like to induce remission rapidly, and then of course maintain steroid-free remission. And so definitely what we are saying over and over again is that steroids are bad. And so the longer we could keep them off of steroids, the better. And this is where the concept of deep remission happens, where we define this as both clinical remission as well as mucosal healing with endoscopic remission. Now, with this mucosal healing, how do we evaluate for that? Could we potentially incorporate some of our other biological markers, which we can also talk about on the panel? And then, of course, certainly we want to be able to modify the long-term disease outcomes for each individual patient. So, of course, we would like to avoid surgery for our patients, avoid hospitalizations, disability. And then we also want to, again, not only minimize the steroid exposure for our patients, but we'd also like to minimize opioids use. And we definitely, especially in the state of Ohio, it is of an absolute concern for our patients as well as nationally. Lastly, let's reduce costs. Let's have our patients on effective, appropriate therapy at the least amount of cost, not just to the system, but then also the cost that it has, that their disease has on them as far as their disease complications and risk, again, of surgery or other disabling disease course. Now, the problem at present is that our current ways that we can actually evaluate disease activity is actually not accurate. So when we're talking about whether we're using our clinical instrument scores, such as the Harvey-Bradshaw Index, or even our endoscopic evaluation, really this is telling us how our patient is doing today. So it only defines really what we call disease activity. In other words, how sick is your patient right now? Disease severity includes elements of prognosis to tell us at how much risk is our patient for their disease progressing and in turn leading to a disabling disease course. So what are some of these prognostic factors or features? Well, here, as outlined both for Crohn's disease and ulcerative colitis, we've been able to identify some of these. We are able to identify which of our patients, whether we're, again, discussing Crohn's disease as listed out here, for the Crohn's patient who is at risk for moderate or high-risk features, and then also for ulcerative colitis, those high-risk features as described, that we are able to say, if you fit some of these high-risk features, you are at a higher risk for disease progression, you're at a higher risk for requiring steroids, hospitalizations, surgery, etc. So what is that natural progression? Well, when we look at Crohn's disease, this is a reminder, again, back to those clinical instruments and scores, really it doesn't matter what those are because, again, we have not yet differentiated for our patient potentially disease activity from disease severity. So you can see that the disease may be active, relapse, remission at certain times, but again, and you've seen this slide plenty of times before, oftentimes we have a very narrow therapeutic window. And so definitely what we need to try to do is achieve early tight control on disease management to reduce the progression or the risk for progression of their disease. And as you all know, we certainly know that there is a difference in our Crohn's patients. So an asymptomatic extensive small bowel Crohn's disease that has moderately active endoscopic lesions. This patient is very different, the amount of inflammatory burden versus the impact of their disease. Conversely, what about an isolated short ileal stricture associated with disabling obstructive symptoms? Again, the burden, the inflammatory burden is less, but the impact of their disease phenotype is very different. So we need to individualize and appropriately tailor our treatment strategies for each of our patients. And when we say, well, what about for ulcerative colitis? Well, unfortunately, today, we don't really have a good story of what is the natural progression of ulcerative colitis. Can we predict that proctitis or proctosigmoiditis patient who's at risk for progressing to pancolitis and requiring a colectomy? Unfortunately, no, we don't have good ways to evaluate or predict that. Not even Brian Fagan can help us predict that. So then we say, what's our next step? So in this situation, we need to be able to, I'm not sure what's happening here. This is Eric, thank you for this. So then we talk about what about the disease severity of ulcerative colitis? Are there features that we also worry about in ulcerative colitis? And the answer is yes. There's different forms, right? Certainly there's different forms that we see that could be structural as well as functional, but let's not equate every patient that you've achieved mucosal healing in ulcerative colitis to now being irritable bowel patient, right? They could have a component of dysmotility or anal rectal dysfunction in combination to their inflammatory bowel disease, to their colitis, as well as perhaps having underlying irritable bowel. But we need to keep this differential or these different forms of ulcerative colitis in mind as well. So we've changed to more objective evaluations when we're discussing treat to target, whether, again, we're talking about ulcerative colitis or Crohn's disease. Gone are the days where we just want you to feel better. Okay, because that's not good enough. And so we're trying to achieve deep remission. Our goal is to be able to do that with being able to have a normal endoscopy, achieve that for our patients, achieve mucosal healing, and in turn improve outcomes for our patients. So again, reducing that risk for hospitalization and need for steroids. So the targets needs to be individualized. I can't stand here and tell you exactly what target is for each of your patients. You absolutely need to individualize it based off of symptoms, age, growth and development factors, laboratory values, mucosal healing, surrogate markers, for example. All of these needs to be individualized for the right patient. And in the past, we used to approach our management very differently than where we are today, right? So in the past, it was this step-up approach or even that top-down approach or aggressive therapy. I hate that word. That last dish, that Hail Mary, that reactive management. Wait till they get really sick and then we'll determine how to modify. But now we're more in a proactive approach where we're doing early appropriate therapy for an aggressive phenotype. So be very careful with this and how we should be approaching this for each of our right patients based off of their phenotype and prognostic factors. So why are we not seeing this? Well, maybe perhaps we're not achieving our outcomes for all of our patients, perhaps because we're starting a little too late with the appropriate therapy for the right patient. Okay? Maybe the therapies are not working. For example, about 20-30% of folks are TNF primary non-responders. Maybe we're treating the wrong problem. Maybe it is irritable bowel and we're thinking it's active inflammatory bowel. So, and then also lastly, maybe we think symptom control is enough. So this was the STRIDE guidelines, and this is part of your ARS. And so this was a group of international team of gastroenterologists that composed both for ulcerative colitis and for Crohn's disease what these targets should be. So for ulcerative colitis, it includes the patient-reported outcomes, and this includes resolution of rectal bleeding as well as diarrhea, as well as endoscopic remission as defined here, with histologic remission becoming an adjunctive goal. For Crohn's disease, here again, we always incorporate patient-reported outcomes, and here is resolution of abdominal pain, as well as their improvement in their bowel habits, as well as endoscopic remission, which is by scope, as well as cross-sectional imaging, so keep that in mind. As far as an adjunctive target, the biomarkers, whether we're talking about a normalization of CRP or calprotectin, should also be considered as far as an adjunctive target. So is it possible? Is it possible to have these as goals? And the answer is actually yes, it is possible. This was a retrospective study by Bill Sanborn's group, and for the patients who are amenable or open to dose optimization or dose adjustments, they studied this. And so they evaluated to see if we could achieve mucosal healing with dose adjustment versus not using this as a target and not necessarily changing their therapies. And on average, it only took about 2 adjustments to a patient's treatment regimen to be able to achieve mucosal healing as well as histologic healing. Then what about REACT? So REACT was actually a randomized cluster study. It was conducted in Europe. It was an algorithmic approach. On REACT, based off of an algorithmic approach for evaluation of those patients who were randomized to the conventional management as opposed to the early combination therapy, they did not achieve their primary endpoint. We could talk about this on the panel as far as why was the primary endpoint not achieved. And primary endpoint was defined as clinical remission at 2 years. However, as far as the secondary endpoint, early combination therapy did help achieve the secondary endpoints, and specifically as outlined, hospitalization and surgeries. The CALM study was the next one in regards to being able to evaluate. And on the left, this was found to be able to evaluate, let me take a step back, to determine if treat-to-target approach was effective. And so on the left, it was the usual clinical management. And then on the right, the patients were randomized to not just the usual clinical management, but also incorporation of some of these additional targets. The additional targets being CRP as well as fecal calprotectin. Patients were randomized as described. Here on the CALM study, the primary endpoint was not clinical remission, such as REACT, but rather mucosal healing. So again, from a treat-to-target approach, we're actually seeing that mucosal healing was significantly better in the treat-to-target group as opposed to the clinical and conventional management group. So how do we approach this? How should we put this all together? The treat to target, and we'll talk about this on the panel, we need to have that initial management. We need to be able to assess and then adjust appropriately as necessary for the right patient, reassess and adjust and keep on monitoring, taking into account a number of different factors, and again, incorporating the patient-reported outcomes as well as our endoscopy and all these other components which we will discuss as additional targets for the right patient. So how do I approach it and how should we all approach it? Again, obtain your initial assessment, start your initial therapy, reassess for disease activity in 3 to 6 months. Are your targets reached for that particular patient? Yes, no. If yes, great. Continue to monitor because how they're feeling today is not how they will necessarily feel tomorrow. If no, are you optimized? Have you evaluated for objective endpoints and targets for each of your patients? If yes, then adjust and continue on. If no, then meet them back in clinic and reevaluate and rediscuss what these targets are for each of your patients. So lastly, the keys to a successful treat-to-target approach obviously requires a willing patient to be able to be as working with you as closely. It also requires informed colleagues, informed providers to be able to proactively manage your patients, recognizing what these targets are. Of course, we need to be able to determine what's the reliable measure for evaluation of disease activity. Remember, not all patients have an elevation of their CRP despite what their inflammatory burden is. Is this a role for calprotectin? We could certainly discuss that. And could some of these strategies even be introduced when we're talking about de-escalation of therapy? So in summary, remember, disease activity is the short term. It's the now, it's the current, as opposed to disease severity, which is more of a long term and really taking into consideration those prognostic factors. Remember, we need to induce remission and keep our patients off of steroids, but be able to evaluate these targets. Keep in mind the STRIDE targets, and remember, we're trying to change the natural history of the disease course for each individual patient. Okay, with that, I thank you. And so now I will have some of my colleagues come up on the panel, and we'll be able to discuss this a little bit further.